In the previous class, we had discussed about hernia and abdominal wall, mainly about inguinal hernia and the types like indirect inguinal hernia, direct inguinal hernia, and the treatment procedures related to that. Okay, now we are starting with other types of hernias, whatever are possible in the abdominal region, starting from femoral hernia. Okay, so most common hernia in both males and females is indirect inguinal hernia. There's no doubt in that. If the question is generally asked, like what is the most common type of hernia, irrespective of males or females, it is indirect inguinal hernia. If they ask the question like femoral hernia is more common in, then the answer is females. Unless and until asked specifically femoral hernia is common in, the answer remains indirect inguinal hernia. This point should be very clear. It's not like femoral hernia when compared in females with femoral hernia and indirect inguinal hernia is more common in females again, but femoral hernia is more common in females when compared to males. Okay, if that point is clear, we are half done. Okay, so this femoral hernia is most common in right side. Okay, and it is bilateral, usually in cases of 20% cases. Usually seen in multipara females because more straining will be there during normal labor. Because of that reason, again, there are two main risk factors for causing hernia. One is weak abdominal wall, another one is increased intra-abdominal pressure. So both occurs in this case where the mother is giving birth to a baby, and because of that reason there is an increased chance of hernia. Okay, and the other one, this truss is a this is a treatment instrument or device, we can say. Basically this is used for conservative management of hernias. So this is like a belt, like lumbosacral belt ನೋಡಿರ್ತೀವಲ್ಲ or it is kind of similar to that, or you can say it is a belt which is worn so that there will be pressure from the outside so that hernia is pushed inside and it is maintained in a reduced state. Suppose if this is a hernia, then this belt is worn in such a way, like ಈ ಥರ ಒಂದು ಬೆಲ್ಟ್ ಇರುತ್ತೆ. This will be tied around the abdomen, and this point where the hernia is actually occurring, there it will be compressing the hernia, and hence it is maintained in a reduced state. So this is a conservative management of hernia, that is called as truss, and this truss is not used in case of femoral hernia. Okay, it can be used only in the cases of inguinal hernia or other hernias, but not used in case of femoral hernia. Okay, so before going to femoral hernia per se, we need to know about the anatomy of the femoral hernia or a femoral canal per se. So yeah, this is the inguinal ligament, and the vessels and nerves pass just below the inguinal ligament, that is femoral vein, femoral artery, and femoral nerve. You can say van from medial to lateral. And just medial to this femoral vein is a canal called as femoral canal, so which is enclosed by a femoral sheath, you can say. So if we have to visualize it more clearly, this is this way in 3D figure. Okay, so this femoral canal is a main culprit in case of femoral hernia, because abdominal content will be herniating through this canal, because it is a open space and it is a hollow space. If there is rise in pressure, the content will be pushed through this. So what exactly is the content of this femoral canal? That is nothing but lymph nodes or lymphatic vessels, lymph node of clockwork, you can say. So this femoral canal is just medial to femoral vein. Okay, and the opening or the surrounding whatever is there, this is called as femoral ring. Okay, and this entire thing which is covering the artery, vein, and this femoral canal is called the femoral sheath. Note that the femoral nerve is not enclosed in the femoral sheath. Artery, vein, and just lymph node is enveloped by this femoral sheath. Okay, yeah. So coming to femoral canal and femoral ring. So femoral canal, just like I said, it is a canal medial to femoral vein, and this is rigid and narrow. Okay, this, because of this rigidity and narrowness of the femoral canal, there is increased risk of strangulation whenever there occurs a hernia through this. So since it is only this much, if the content is too big, so what this causes, it will cause obstruction, and if the blood supply is also lost along with obstruction, then that is called as strangulation, just like a strangulated inguinal hernia we had studied. Similarly, this will lead to increased risk of strangulated femoral hernia. Okay, hence, since there is an increased risk of strangulation, if there is a patient of femoral hernia, we have to perform surgery as early as possible to prevent strangulation. So, what is the diameter of this femoral ring? Femoral ring diameter is again 1.25 centimeter, and it is also in length, it is 1.25 centimeter. Both diameter and length are equal, that is 1.25 centimeter. Okay. So, what is the main content here? Clockwise group of lymph nodes is the main content in case of femoral canal. So, how will the patient present to us in case of femoral hernia? Just like we all know, it will be a swelling in the inguinal-scrotal region. And yesterday also we had discussed, based on the location of the swelling, we will be deciding if it is a inguinal hernia or if it is a femoral hernia. So, inguinal hernia, just like we all know, anterior superior iliac spine and pubic tubercle, this will be the inguinal ligament. If the hernia is medial to pubic tubercle, then that will be inguinal hernia. If the hernia is lateral to pubic tubercle, then it will be femoral hernia. So, swelling which is below and lateral to pubic tubercle will be the clinical presentation. Okay. So, yeah, just like we all know, diagnosis is basically clinical diagnosis. Once we palpate the hernia and once we come to know that it is lateral and below the pubic tubercle, we will say, okay, this is a femoral hernia, and usually females will be the ones who will be presenting with this femoral hernia. So, based on all those findings, we will diagnose this as femoral hernia. So, how will we treat it? Again, surgical. We can't use conservative management also, like truss. Just in order to postpone surgery, we can use truss in case of inguinal hernia. Suppose the patient is having cough now and he is having hernia also. So we can't operate on the patient now because of cough. Again, there will be recurrence. So what we'll do, we'll say to the patient, okay, you clear your cough and come. Until then, use this belt called truss so that hernia won't get bigger one. So in that case, you can use it. But in case of femoral hernia, we have to operate as early as possible, and hence surgery is a mainstay of treatment in this case. So surgery can be, hernia can be approached from high inguinal or low inguinal. Based on this, there are various approaches. So subinguinal incision kotbiಟ್ಟು we can approach femoral hernia. So if the incision is below the inguinal canal or below the inguinal ligament, that is subinguinal approach, and it was performed by a scientist, and hence the name Lockwood subinguinal incision, or you can remember it by low Lockwood incision. Okay, low Lockwood incision. So this is the approach. Other one being on the inguinal ligament, or just like an inguinal hernia, we will open over the inguinal region, and then we will perform femoral hernia surgery, and that is called as Lothisen inguinal incision. Okay, and other one being suprainguinal incision. Above the inguinal ligament, we are performing incision and then performing the surgery. That is high McEvedy, you can say. High McEvedy and low Lockwood. These are the two main important approaches for repair of femoral hernia. Okay, other one being the treatment of choice for femoral hernia is Henry's procedure. This is a midline, abdominal and extraperitoneal femoral hernioplasty. So everything is in the sentence itself. It is incision is in the midline of the abdomen, and we are not entering the peritoneal cavity, that is extraperitoneal, and we are performing a hernioplasty, that is we are reducing the hernia, femoral hernia, and then we are putting a mesh. So that is femoral hernioplasty. So this is the treatment of choice, but usually they will perform that is low Lockwood or high McEvedy. This incision is performed most commonly because midline abdomen alva. So ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, incisional hernia will be a complication or a risk factor. After operation, there can be a risk of incisional hernia in case. So that's why usually they'll prefer this low Lockwood and McEvedy. Okay. There are various types of femoral hernia also. Just like we had discussed in inguinal hernia, there was bubonocele, there was funicle. Similarly, various variants are there of femoral hernia. First variant being Laguer's hernia, that is hernia through gap in the lacunar ligament. So lacunar ligament is nothing but a modification of inguinal ligament itself. If there is a gap in this lacunar ligament and if there is herniation of the content through that gap, then it is called as Laguer's hernia. Then Cloquet hernia is located between the pectineus fascia, then it is called as Cloquet hernia. And Narath hernia, so this is seen in conditions like congenital dislocation of hip. In this, there will be lateral displacement of the sac, and sac will be located behind the femoral vessels. Okay, so we might have studied about vascular sign of Narath in case of mm, the peripheral vascular disease or varicose veins. During that time, we will be studying vascular sign of Narath. So, similar scientist name, that is Narath hernia. Okay, so these are the variants of femoral hernia, we can say. So this was about femoral hernia. Just in brief, so patient will be presenting with swelling in inguinoscrotal region, and on palpation it will be lateral and below the pubic tubercle. So treatment of choice is Henry's procedure, but low Lockwood and high McEvedy is performed most commonly. Other things being variants of femoral hernia, 3 names. Okay. After this, we are coming to other special type of hernias, and the first one being Spigelian hernia. Okay. So yesterday while we were discussing, I had told about this Spigelian hernia. Like most commonly, hernia is a clinical diagnosis. But one exception was there, and that exception was this Spigelian hernia, because it is an internal hernia. Okay, unless we do some scanning or unless we visualize it in some other way, we won't come to know that there is a hernia, because what is exactly happening anta gottagutte illi. So hernia through this Spigelian fascia. Is Spigelian fascia illide gotta? This is in the infraumbilical region. Suppose you are seeing this, so here is the umbilicus, right? So below that there is fascia. So in the just below the this line called arcuate line. So whatever this line you are seeing, below this line is a fascia called as Spigelian fascia. So here whatever the fascia is there, that will be weak. Okay, so because of that reason there will be herniation of this contents, and that leads to Spigelian hernia. Okay, so this is located in the infraumbilical region and below the arcuate line. So most of the hernias are usually in the infraumbilical region due to absence of posterior rectus sheath. Okay, so what you need to know is, suppose we are seeing a transverse section of the abdomen anta ankolona. So this is rectus abdominis muscle. Aita, just like we all know, rectus abdominis muscle is covered by a sheath called rectus sheath, and this rectus sheath will divide into one or two components. So it's like anterior and posterior. Okay, so based on this splitting of rectus sheath also, there are various theories, like external oblique muscle will come and form part of rectus sheath, and then similarly. Okay, so there are theories like rectus sheath is covered by 3 layers in front and 3 layers in back. Ee tara one theory helutte. What other theory says is, it's like only the anterior lip or only one anterior is covering like this from the external oblique muscle, and the rest of the things are covering like this. So it's like posteriorly 4 are there and anteriorly 2 are there. So okay, so this arrangement is there only till arcuate line. Okay, so if this is abdomen, umbilicus, so here arcuate line is there. So till here, whenever there is muscle, this is rectus abdominis muscle, so this covering will be throughout this. Okay, and just like they say, till here anteriorly 2 layers will be there and posteriorly 4 layers will be there. After this, these 4 layers will not be there. So posteriorly there is less support to the rectus abdominis muscle. So because of this reason, this gap, whatever is there posteriorly below the arcuate line, it will be weaker. So because of this reason, that is absence of fascia or absence of or weakness of the rectus sheath, you can say. Weak rectus sheath is present below the arcuate line, and because of this reason there will be herniation, and that herniation is called as Spigelian hernia. Okay, so this Spigelian fascia is a thin aponeurosis located between the rectus abdominis muscle medially and the semilunar line laterally. So what you can say is this is rectus abdominis muscle, and just lateral to this will be another line called as, okay, so semilunaris line or semilunar line you can say. So between these two layers below the arcuate line is this fascia called as Spigelian fascia. So just between these two, that is rectus abdominis muscle and the semilunar line, there is this fascia, and if there is herniation through this fascia, then that is called as Spigelian hernia. Okay, everything is about anatomy. If we know anatomy well, then hernia is piece of cake. Okay, so Spigelian fascia is just thin aponeurosis located between the rectus abdominis and the semilunar line, also known as interparietal hernia, because it is located between the internal oblique and external oblique and penetrates the Spigelian fascia. Okay, this is located behind the external oblique, hence not palpable or visible. So ಇದು ಮಸಲ್ ಒಳಗಡೆ ಇದೆ, ಲೈಕ್ ಇದ್ರ ಮೇಲ್ಗಡೆ ಮಸಲ್ ಇದೆ ಥ್ರೂ ಔಟ್, ಎಕ್ಸ್ಟರ್ನಲ್ ಆಬ್ಲಿಕ್ ಮಸಲ್. ಸೊ ಆಚೆ ಕಡೆ ಕಾಣಿಸಲ್ಲ, ಬಟ್ ಒಳಗಡೆ ಅಬ್ಡೋಮಿನಲ್ ಪೇನ್ ಏನೋ ಆಗೋದು ಈ ಥರ ಆಗ್ತಾ ಇರುತ್ತೆ. ಓಕೆ, ಸೊ ಆ ಪ್ರೆಸೆಂಟೇಷನ್ ಇದ್ದರೆ ಇಟ್ ಈಸ್ ಕಾಲ್ಡ್ ಎಸ್ ಇಂಟರ್ನಲ್ ಹರ್ನಿಯಾ. ಅದಕ್ಕೆ ಅಬ್ಡೋಮಿನಲ್ ಪೇನ್ ಇರುತ್ತೆ, ಬಟ್ ಏನಾಗ್ತಿದೆ ಅಂತ ಗೊತ್ತಾಗ್ತಿರಲ್ಲ. ವೆನ್ ವಿ ಡೂ ಎ ಯು ಎಸ್ ಸಿ ವಿಲ್ ಕಮ್ ಟು ನೋ ದಟ್ ದೇರ್ ಇಸ್ an internal hernia happening here, and hence the name Spigelian fascia or internal hernia. Okay, yeah. So what will be the clinical presentation of the patient? Yeah, just like I have said, swelling will be neither visible nor palpable, leading to delayed presentation. So unless we do some scanning in order to rule out this abdominal pain, or in order to find the cause of this abdominal pain, we won't come to know that there is a hernia. Hence there will be delayed presentation. Okay, so if there is a delay in presentation, there will be delay in diagnosis and increased risk of strangulation. Investigation, yeah, we can't diagnose this by clinical examination, hence it was an exception. Diagnosis is usually by USG or CT. How will we manage it? Just like all other hernias, we will open up, do a surgery, reduce the herniated content and close back the defect. Okay, yeah, this was about Spigelian hernia. So now in this class we had discussed already about femoral hernia and Spigelian hernia. Next hernia being sliding hernia. Similar to what we had discussed during diaphragmatic hernia, there will be a defect. Along with that, through that defect there will be sliding of certain contents, hence the name sliding hernia. So here posterior wall of sac is formed with a viscera, and there is increased risk of bowel injury during ligation of this sac because it involves viscera. Okay, so just like this. So here this is the sac and this is the posterior wall of the sac, and it is involving the bowel also. So whenever we are trying to open up this sac, there will be possibility that we will injure this bowel. Okay, so this is usually known to be more common during left side, and most common content being sigmoid colon. Usually more common in females when compared to femoral hernia. It is more common in females. More common in males. Sliding hernia is more common in males, and usually right side ಆಗಬಹುದು. Right side ಆದರೆ content will be cecum. Okay, what will be the management? Management is same again, removal of the sac along with the content. If the content is viable, then we will reduce the content. If it is strangulated, then again take off the content also, and then close or repair the defect. So basically it is like there is a defect and this content is sliding through this, hence the name sliding hernia. So since the content is sliding, one of the sac wall will be bowel also. Okay, yeah. Next hernia being lumbar hernia. So lumbar hernia is the herniation in the lumbar region of the posterior abdominal wall. So this hernia we can see from back side. Okay, if we are visualizing the back of the patient, then usually from two regions there will be this hernia, and those two regions are the defect in the posterior abdominal wall. Just like in the anteriorly we have Hasselback's triangle, there are two other triangles where posterior abdominal wall has natural defects. So if there is herniation of the content through those natural defects in the posterior abdominal wall, then that hernia is called as lumbar hernia. Okay, so this is usually most common on the left side because of anatomy, and it can be congenital or acquired, and congenital is usually seen in 20%, whereas acquired is more common, that is 80% of the cases. Most of the lumbar hernias are occurring through two triangles, and among those two triangles it is most commonly occurring in superior triangle of Greenfield. Okay, Greenfield you can say, and some of the lumbar hernias are occurring through another triangle called as inferior triangle of Petit. So where are these triangles exactly? Okay, so yeah, First one being superior triangle, superior lumbar triangle, and transversalis fascia, they have mentioned here. Okay, so yeah, what are the boundaries of this superior triangle of Greenfield and Kelidra? It is posteriorly, it is the paraspinal muscle. Okay, we'll torso idralli. Fine. Superiorly there will be 12th rib. So this is a 12th rib, this is a paraspinal muscle, and then there is anteriorly there is internal oblique muscle. So this internal oblique muscle will be covering the entire abdomen, and then posterior will be coming posteriorly and will be forming this. Okay, so this is a triangle, and this triangle is called as superior triangle of Greenfield. Why is it superior triangle? Because there is one more triangle which is inferior to this, that is inferior triangle of Petit. Okay, so inferior triangle of Petit, the boundaries ಏನಂತ ಕೇಳಿದ್ರೆ it is easy. So yeah, posteriorly that is latissimus dorsi. Okay, and then inferiorly that is iliac crest, and then anteriorly it is external oblique muscle. So this triangle here is the inferior triangle of Petit, and this triangle here is the superior triangle of Petit, superior triangle of Greenfield, sorry. So most commonly it will happen through this superior triangle, and some hernias can happen in this inferior triangle of Petit also. So clinical features ಏನಿರುತ್ತೆ, yeah, again there will be swelling in the lumbar region, you can say, that is unilateral bulge ಇರುತ್ತೆ in the lumbar region, and defect usually will be very large, so patient is not not aware mostly. Okay, so defect very large ಇದ್ರೆ ಏನಾಗುತ್ತೆ, it will come and go, it will not stay there, like obstruction ಆಗಲ್ಲ. These will be easily reducible, and for that reason patient won't be knowing unless someone else will notice from behind, like okay, when you are coughing or when the intra-abdominal pressure increases, there is some part of the bowel or some content is coming out ಅಂತ ಯಾರೊಬ್ರು ನೋಡಿ ಹೇಳೋವರೆಗೂ ಅವ್ರಿಗೆ ಗೊತ್ತಾಗ್ತಿರಲ್ಲ. Hence it is usually delayed presentation only. So unilateral bulge ಇರುತ್ತೆ lumbar region ಅಲ್ಲಿ, and strangulation is very rare because large defect, easily it will be reducible, obstruct ಆಗಲ್ಲ. So obstruct ಆಗಲಿಲ್ಲ ಅಂದರೆ strangulate ಆಗಲ್ಲ. So management is just remember the name, Dowd's operation in case of lumbar hernia. Okay, next hernia being obturator hernia. Again, obturator foramen is a natural defect present in our pelvis. So if there is a hernia through that obturator foramen, then it is called as obturator hernia. Again, this is also called as skinny old lady hernia. Unless the patient is very skinny, we won't be able to visualize this hernia. Hence it is also called as skinny, that is thin, and old lady, because collagen adu idella, I mean there will be what we can say, weakness in the abdominal wall, and because of that reason there will be herniation. This is also called as French hernia. Due to loss of fatty tissue in the obturator canal, this hernia happens. Okay, again you can see the content. So this is the obturator foramen here, and there is herniation of the content through obturator foramen, and that is called as obturator or skinny old lady or French hernia. So what are the risk factors? When does this hernia develop actually? So it is seen in lean and thin patients who are chronically malnourished. Okay, and then elderly females or multipara patients, chronic constipation, other risk factors which increase intra-abdominal pressure. Basically patient should be thin, and whatever the factors leads to patient being thin, malnutrition ಇರ್ಬೋದು, ಅಥವಾ elderly females ಇರ್ಬೋದು, ಅಥವಾ multipara patients ಇರ್ಬೋದು, or chronic constipation, like this chronic constipation will lead to increase in intra-abdominal pressure. Okay, so these are the risk factors. How will the patient present to us? Patient will present usually with pain along the medial aspect of the thigh radiating to same sided knee joint. So usually imagine this is right thigh and this is left thigh. So right sided obturator hernia is happened. Usually we won't come to know. And what will be the symptom? Because of compression of this obturator nerve. We all know obturator nerve is coming from this obturator foramen only. So if there is compression, where will this obturator nerve supply? This will be supplying medial side of the thigh. It is a medial compartment. So over there will be pain, and similarly there is a branch from this going to the same side knee joint. Hence there will be radiation of this pain from thigh to knee joint. So one can be that sign, that is pain which develops in the medial aspect of the thigh, and that goes to ipsilateral knee joint. That is called as Hauschie-Bromberg sign. Other sign being absence of this obturator reflex only, and that is called as Huntington-Kiff's sign. So these two signs will be the clinical presentation. Okay, so what will be the treatment? Repair by posterior approach. That is, we can't do anything anteriorly, we have to go through the posterior approach and pull back the content. So that is repair by posterior approach. So this is about obturator hernia. Next one being epigastric hernia. So usually in hernia they will ask more about inguinal and femoral hernia. Rest all hernias are just for our knowledge sake. Like all these hernias are there. These are one or two markers they can ask you, but these can be asked for long answers. So focus mainly on this, but know about other hernias also. Okay. So epigastric hernia, just like the name suggests, it will be seen in the epigastric region above the umbilicus. So here is the umbilicus. Above that, in the midline, a hernia is seen, that is called as epigastric hernia. Usually what will be the content under fat will be the content. Okay. Hence it is known as epigastric lipoma because fat will be the most common content here. So any hernia from the xiphoid process till 2 cm of umbilicus, it is called as epigastric hernia, and it is also known as fatty hernia of linea alba because it is occurring in the midline, and midline aliro line ಹೆಸರೇನು linea alba. So hence it is known as fatty hernia of linea alba. So 80% cases ಅಲ್ಲಿ midline unilateral ಇರುತ್ತೆ, ಒಂದೇ ಒಂದಿರುತ್ತೆ. ಮಲ್ಟಿಪಲ್ ಇದ್ದರೆ 20% ಕೇಸಸಲ್ಲಿ ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಮಲ್ಟಿಪಲ್ ಆಲ್ಸೋ. ಸೊ ಯೂಶಲಿ ಇಲ್ಲಿ ಏನಾಗುತ್ತೆ, ದರ್ ವಿಲ್ ಬಿ ಪೇನ್ ಆ್ಯಂಡ್ ದಿಸ್ ಪೇನ್ ವಿಲ್ ಬಿ ರೆಫರ್ ಟು ಎಪಿಗಾಸ್ಟ್ರಿಕ್ ರೀಜನ್ ಆ್ಯಂಡ್ ಇಟ್ ವಿಲ್ ಬಿ ಜಸ್ಟ್ ಲೈಕ್ ಪೆಪ್ಟಿಕ್ ಅಲ್ಸರ್. ಸೊ ಒನ್ ಆಫ್ ದ ಡಿಫರೆನ್ಷಿಯಲ್ ಡಯಾಗ್ನೋಸಿಸ್ ಯು ಕ್ಯಾನ್ ಸೇ ಇನ್ ದ ಇನಿಷಿಯಲ್ ಸ್ಟೇಜಸ್. ಓಕೆ, ಟ್ರೀಟ್ಮೆಂಟ್ ಏನು? ಇಫ್ ಇಟ್ ಈಸ್ ಟೂ ಮಚ್ ಪ್ರಾಬ್ಲಮ್ಯಾಟಿಕ್, if it is causing too much pain, only then we will go for repair, and that is called as pre-peritoneal fat repair, that is excision. So basically ಇಲ್ಲಿ ಏನು ಫ್ಯಾಟ್ ಬಂದು ಹರ್ನಿಯೇಟ್ ಆಗಿರುತ್ತೆ, ಈ ಫ್ಯಾಟನ್ನು ತೆಗೆದಾಕ್ತಾರೆ ಅಷ್ಟೇ, ಎಕ್ಸಿಷನ್ ಆಫ್ ದಿಸ್ ಫ್ಯಾಟ್. ಆ್ಯಂಡ್ ಇಫ್ ದ ಸೈಜ್ ಆಫ್ ಡಿಫೆಕ್ಟ್ ಈಸ್ ಮೋರ್ ದೆನ್ 4 cm, then we'll put a mesh in order to strengthen the abdominal wall ಅಷ್ಟೇ. Okay, so this was about epigastric hernia. Then coming to umbilical hernia. So this hernia is directly occurring through the umbilicus. There is other type of hernia called as para-umbilical hernia within 2 cm of the umbilicus, but not through the umbilicus, hence the name para-umbilical hernia. Okay, so here you can see this is umbilicus, and umbilicus in the hernia ಆಗ್ತಿರೋದ್ರಿಂದ it is umbilical hernia, whereas para-umbilical hernia ಅಂದರೆ 2 cm around ಎಲ್ಲೇ ಆದರೂ that is para-umbilical hernia, and it will not come through umbilicus. So okay, para-umbilical hernia usually will be seen in cases of ಏನಂತಾರೆ incisional hernias only. ಆಯಿತಾ? ಯಾ, in infants usually umbilical hernia is congenital and it is more commonly seen in Africans, and it closes spontaneously in majority of cases by 2 years. Okay, complications usually rare, there won't be any complications. Okay, what is the treatment for umbilical hernia? Usually we'll do surgery if it is too problematic. Like congenitally children alladre until 2 years we'll wait, and if it resolves spontaneously it's fine. Otherwise we can go for surgery there also. Like if it persists beyond 5 years we can go. Otherwise if there is an umbilical hernia and if it is causing persistent symptoms like bloody discharge from there, or any discharge from there, or too much pain or constipation, any symptoms like these, we will have to go for surgery again. If there is strangulation, it will cause severe pain and blackish discoloration of skin around the umbilicus, then we will have to perform surgery. If the size of the defect is more than 2 cm, again we will have to perform surgery. Then if there is progressive enlargement of hernia, initially it was only just 1 cm, now it has become too large, so over 1 or 2 years, then progressive enlargement is there, so then we will perform surgery. Maximum time to wait is 5 years. Within 5 years we will perform surgery. After that again it may lead to complications. We can wait if there is small defects because it will close primarily. Okay, if the size of the defect is more than 3 cm, we will have to put a prosthetic mesh. There is a procedure called Mayo's repair. This is also known as vests over pants repair. These are not usually performed because of increased tension which is associated with this repair. Okay, yeah. So these are the various types of hernia you can see in the abdomen region which we have discussed till now. First one being inguinal hernia. It is commonly seen in this inguinal region and it will be medial to the pubic tubercle. Okay, and next one being femoral hernia, that will be lateral to the pubic tubercle. After that we discussed about Spigelian hernia, that is in the infraumbilical region below the arcuate line. After that there can be an incision hernia because there will be abdominal wall defect because of the previous underwent surgery, and because of that reason there is hernia happening there. After that umbilical hernia, through the umbilicus there will be a defect. Epigastric hernia, it is also known as epigastric lipoma you can say, because of fatty herniation. Okay. So these were the various types of hernia we have studied till now. Next, coming to some congenital abdominal wall defects, we can say. So these are usually seen in soon after birth. Okay. So there are mainly two types. One is omphalocele, other one being gastroschisis. We'll study about omphalocele first. So while there is development of hernia or development of abdomen happening, basically GI tract we can say, during embryology. So we all know there is a physiological hernia there. So it's like midgut will be protruded like this, and there will be a vitalointestinal duct. Along with that, there will be allantois. Okay. So and this hernia will regress on its own by 10 or 12 weeks. Okay, it should happen naturally. That is physiological hernia, and it will regress on its own. If that physiological hernia doesn't regress, then it will lead to various manifestations. One being omphalocele, that is intestine fails to return to the intra-abdominal cavity. This causes omphalocele. So this will be usually in the midline. Okay, just like we see in this diagram, it is usually in the midline, and usually it is covered by two layers, amnion and peritoneum. Okay. For small defect, protrusion of small amounts of bowel will be there. If there is a large defect, protrusion of small bowel along with liver will be there. Okay. Usually congenital ಆಗಿರೋದ್ರಿಂದ this will be associated with some other syndromes also, like trisomy 13, that is Edward Patau syndrome and Down syndrome. ಈ ಮೂರು ಟ್ರೈಸೋಮೀಸ್ ಜೊತೆಗೆ ಅಸೋಸಿಯೇಟೆಡ್ ಆಗಿರುತ್ತೆ omphalocele. It is also associated with some other congenital malformations also, like not only GI system but CVS, musculoskeletal and genitourinary system can also be involved. Most common cause of death, again, congenital malformations. This is also associated with a syndrome called as Beckwith-Widman syndrome, which is a variant of the Wills tumor of kidney. ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, hemi hypertrophy, macroglasia, that is a large tongue, organs are enlarged. Along with that, omphalocele, which we are studying now. Along with that, there is a most common primary tumor of liver in children, that is hepatoblastoma. These all conditions will be associated, and that syndrome is called as Beckwith-Widman syndrome. So this omphalocele is known for its poor prognosis if there are associated congenital malformations. Otherwise, the second disease being gastroschisis. ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, ಆನ್ ದ ರೈಟ್ ಸೈಡ್ ಮೋಸ್ಟ್ ಕಾಮನ್ಲಿ ವಿ ನೋ ಲೈಕ್ ಅಂಬಲಿಕಲ್ ವೆಯ್ನ್ಸ್ ಮತ್ತು ಅಂಬಲಿಕಲ್ ಆರ್ಟ್ರಿ. ಸೊ ವೈಟ್ ಲೈನ್ ಆರ್ಟ್ರಿ, ಈ ಥರದ್ದೆಲ್ಲ ಬೇಸಿಕಲಿ ಎವ್ರಿಥಿಂಗ್ ಈಸ್ ರಿಲೇಟೆಡ್ ಟು ಎಂಬ್ರಿಯಾಲಜಿ. ಓಕೆ, ಸೊ this is usually common in right side of the abdominal wall because there is an obliteration. This side, right side, illi obliteration of white line veins or umbilical vein happens. So obliteration agutte one vein on the right side. Okay, right umbilical vein anta ankoli. So aa jagadalli enagutte, abdomen should come and fuse because initially there was vein, now the vein has obliterated and it should be covered by the skin and wall. If that skin and wall failure happens, if that won't come and fuse, then there will be a defect over there, and through that defect there will be this hernia. Okay, so that is called as gastroschisis. Okay, here the bowel is exposed, it is not covered by amnion and peritoneum just like it was covered in omphalocele. It is direct bowel is directly exposed to the environment in case of gastroschisis, and it is usually associated with intestinal atresia. So risk factors ಏನಿರುತ್ತೆ, in this case the mother consuming alcohol, smoking, aspirin during first trimester, ibuprofen or pseudoephedrine, ಈ ಥರದ್ದು ಏನಾದರೂ ಡ್ರಗ್ಸ್ ಇಂಟೇಕ್ ಅಥವಾ ಆಲ್ಕೋಹಾಲ್ ಸ್ಮೋಕಿಂಗ್ ಆದರೆ there will be delayed healing, you can say. So collagen formation will be delayed. ಆಯಿತಾ, ಕೊಲಾಜನ್ ಫಾರ್ಮೇಷನ್ ಡಿಲೇ ಆಯ್ತು ಅಂದರೆ ಇವಾಗ ಒಂದು ಆ ಜಾಗದಲ್ಲಿ ಆಬ್ಲಿಟ್ರೇಷನ್ ಆಗಿದೆ ಅಂಬಲಿಕಲ್ ವೈನ್, ರೈಟ್ ಅಂಬಲಿಕಲ್ ವೈನ್, ಬಟ್ ಆ ಜಾಗಕ್ಕೆ ಕೊಲಾಜನ್ ಬಂದು ಫಾರ್ಮ್ ಆಗೋಕ್ಕೆ ಡಿಲೇ ಆಯಿತು. ಸೊ ಅಷ್ಟರಲ್ಲಿ ಬೇಬಿ ಬರ್ತಾಯಿತ್ತು. ಸೊ ಡಿಲೇ ಆಗಿರೋದ್ರಿಂದ ಏನಾಯಿತು, ದರ್ ವಿಲ್ ಬಿ ಪ್ರೊಟ್ರೂಷನ್ ಆಫ್ ದ ವಾಟ್ ಎವರ್ ದ ಕಂಟೆಂಟ್ಸ್ ಆರ್ ದೇರ್ ವಿತ್ ಇನ್ ದ ಅಬ್ಡಮೆನ್, ದೇ ವಿಲ್ ಬಿ protruded out, and that condition is called as gastroschisis. Usually the age of the mother will be less than 20 years. Okay, these are not associated with any other congenital anomalies or other syndromes, hence usually this is having good prognosis. So these two things they will ask usually as a differentiate. So omphalocele and gastroschisis differences ಗೊತ್ತಿರಬೇಕು. Okay, we'll come to this once we are revising things. Okay, So next one hernia being incisional hernia. This is also called as post-operative ventral wall hernia, because after some surgical event usually this hernia will happen. This is caused by failure or fusion of the facial tissues, that is fascia or connective tissue. Okay, ಇದು ಫ್ಯೂಷನ್ ಆಗಲ್ಲ ಹರ್ನಿಯಾ ಆದಮೇಲೆ, ಐ ಮೀನ್ ಆಪರೇಷನ್ ಆದಮೇಲೆ there is no proper healing because of this fascia or connective tissue, and because of that reason there is protrusion of the contents, and that is called as incisional hernia. During laparotomy, with the help of Prolene suture, that is non-absorbable suture, or subcutaneous fat is usually closed with Vicryl or catgut, and skin is usually closed with skin. After laparotomy, rectus sheath is closed. If there is failure of fusion of facial tissues, there will be herniation of the bowel, hence there will be increased risk. Okay, when we say that there is an increased risk for incisional hernia andre in cases of long vertical and midline and lower abdominal incisions. So if the incision is too long, if the incision is vertical not horizontal, if the incision is in the midline, or if there is lower abdominal incision, then these all will be a risk factor for developing incisional hernia. So whenever you are performing any surgery which involves this type of incision, you have to explain the patient as this incisional hernia as a complication. Like in hernia, I mean we are operating so and so, we will be putting so and so incision. Later on, if there is no proper healing, it can lead to incisional hernia. You must know this. Okay, so what are the risk factors for incisional hernia? Surgery related, that is if we are performing some emergency surgery, like suppose a patient has undergone trauma and we are performing or if there is any organ injuries like liver laceration or splenic laceration, splenic rupture, ಈ ಥರ ಏನಾದರೂ ಆಯ್ತು ಅಂದರೆ immediately we have no time, immediately we have to open the abdomen up, so we'll put unplanned incisions we can say, okay, or vertical long incisions ಹಾಕ್ಬಿಡ್ತೀವಿ. ಸೊ ಆ ಟೈಮಲ್ಲಿ ಏನಾಗುತ್ತೆ, there will be increased risk of incisional hernia in case of emergency laparotomy or emergency surgeries, and surgeries with wound infections, like if there is an infection already and we are performing surgeries over that, there will be increased chances of hernia because of poor healing. So surgeon related, so this was surgery related, surgeon can do nothing here, but here experience of the surgeon matters. Like if there is a poor technique, if the surgeon is not closing the wound properly, if the suture is not appropriate, or if the surgeon is not closing it under tension, or there is use of absorbable sutures, then all this will lead to improper healing, and that can lead to incisional hernia. Patient factors, this is most common in our country, because if there is diabetes which is uncontrolled, there will be improper healing. Other than that, steroid intake, HIV positive, again immunocompromised state, so this will lead to increased infections, and that will lead to improper healing. Similarly, jaundice and cirrhosis, these all can lead to improper healing. So if there are associated risk factors, then it can lead to incisional hernia. Okay, so what is the treatment for incisional hernia? Gold standard treatment being intraperitoneal onlay mesh repair. So again, open the peritoneum and place a mesh over there and then close the defect. So that is intraperitoneal onlay mesh repair. So recurrence rate is more than 50%. Onlay or overlay andre placing the mesh above the facial sheath. Okay, so yelli heal, I mean where the facial sheath hasn't healed properly, over that we will put. So if this is a fascia, we will put a mesh here. So this is onlay. Okay, inlay or interlay andre suturing the edges of the mesh through the sheath without closure, and this is least commonly performed. So here they are showing. So this is subcutaneous onlay or overlay technique. Okay, just below the peritoneum, over the defect, they are placing the mesh. Okay, if it is underlay andre they are placing it below the facial sheath. Okay, ಅದಕ್ಕೆ underlay ಅಂತ ಕರೀತಾರೆ. Intra-abdominal, intraperitoneal, that is below the peritoneum. This is a peritoneum, and if they are placing it below the peritoneum, then that is called as intra-abdominal, intraperitoneal onlay mesh repair. Okay, the rectus sublay, okay, just below the rectus sheath. So basically again you will have to know the layers of the abdomen, and after that it will be easy. So they have shown everything here only, I'll try to explain it here. Yeah, the first one being skin, then subcutaneous tissue or fat. Okay, after this is the whatever the muscle we will get, that is rectus abdominis muscle. Okay, ಇದು ಮೇಲ್ಗಡೆ ಇರೋದು ಎಕ್ಸ್ಟರ್ನಲ್ ಆಬ್ಲಿಕ್ ಇರ್ಬೋದು. This is rectus abdominis. Again this is forming rectus sheath. Then under that will be the conjoint tendon, you can say, that is internal oblique, and then transversus abdominis. After that will be peritoneum. This is peritoneum. So if you place a mesh between rectus abdominis and internal oblique, that is called as retrorectus or sublay. Okay, so basically where you place the mesh, based on that we are labeling it. So subrectus or sublay. Okay, if the mesh is placed below the internal oblique and this thing, below the internal oblique but above peritoneum, then it is called as underlay, that is pre-peritoneal. This is retrorectus, this is underlay or pre-peritoneal. Okay, if we place it under the peritoneum, then this is IPOM or intraperitoneal onlay mesh. Okay, so this is gold standard treatment. Other than that, just below the this thing, just below subcutaneous tissue we place a mesh, that is called as subcutaneous onlay. Godaitalla? So basically if we draw the layers of the abdomen, we will come to know based on what they have labeled the technique anta. So onlay, sublay, underlay ಎಲ್ಲ ಗೊತ್ತಾಯ್ತು ಇದರಲ್ಲಿ. Okay, next one, uncommon tumor, that is desmoid tumor, which arises from the musculo-aponeurotic structures in the infraumbilical region. Okay, so hence since it is arising from muscle or aponeurotic structures in the infraumbilical region, we are studying it in this chapter so that for completion's sake. Okay, so this is usually unencapsulated and cracks whenever it is being cut. So what are the risk factors for development of desmoid tumor? If there is a history of surgical incision, just like incision hernia, there is a history of surgical incision, and estrogen stimulates the growth of this desmoid tumor, hence it is usually most common in females. We can also say that this is a variant of FAP, that is a familial adenomatous polyposis or Gardner's syndrome, in which there is increased risk of desmoid tumor. Other than that, there are no sarcomatous changes, no distant metastasis, and increased risk of recurrence despite the excision. So distribution ellaguttandre usually extra abdominal in 60% cases, involves the abdominal wall in 25%, and intra abdominal in 50% cases. So for this 25% we are studying it under abdomen. Okay, so clinical features enirutte, from the muscle there is arising a mass, and that lump or mass is desmoid tumor usually. How will we diagnose it or investigate it? Investigation of choice is MRI. Desmoid tumor, it is a soft tissue tumor, so whenever we visualize it under MRI, we will be able to visualize a soft tissue tumor which is arising from the musculo-aponeurotic structures of abdomen in the infraumbilical region. So how will we treat it? Once we get to know that it is a desmoid tumor, we will treat it by wide local excision with leaving a 2 cm margin. So if this is a tumor sutta 2 cm ಅಷ್ಟು we will excise, that is called as wide local excision. Recurrent ಆದರೆ surgery and again radiotherapy ಕೊಡಬೇಕಾಗುತ್ತೆ. Okay, so this was about desmoid tumor. There are certain MCQ points or certain one-liners we need to know regarding hernias. So we had studied regarding some named inguinal hernias, that is amyand hernia, litter hernia. Inguinal hernia related ಓದಿದ್ವಿ. There are some other hernias overall in general, not inguinal, other hernias which are named, and we need to know this from MCQ point of view. So first one being Gibbon's hernia, in which there is hernia and hydrocele. Okay, so that is Gibbon's hernia. So Berger hernia, idu hernia in the pouch of Douglas. Okay, so Becklar's hernia andre hernia through the saphenous opening. Ogilvie's hernia, again hernia through the defect in the conjoint tendon. So Stammer's hernia andre hernia through the transverse mesocolon after rectocolic gastrojejunectomy. So we perform a surgery, that is retrocolic gastrojejunectomy. After that there will be hernia through this transverse mesocolon. That hernia is called as Stammer's hernia. Peterson hernia, hernia behind the row limb after row and Y gastric bypass. That is Whipple's procedure anta ankolli. Whipple's procedure we will perform for some gastric tumors or something. After that, if there is a hernia through that row limb, whatever we have left, that hernia is called as Peterson hernia. So this Stammer's hernia and Peterson hernia are important because these are developed after surgeries. So this is a complication. Okay. Velpeus hernia, again, it is a prevascular hernia. It is located in front of the femoral vessels. Seraphinis hernia, this is a retrovascular hernia. It is located behind the femoral vessels. So this is in front and this is in behind femoral vessels. Holthaus hernia, this is a type of inguinal hernia and extension of bowel is along the inguinal ligament. Okay, note Ogilvie syndrome andre it is nothing but colonic pseudo obstruction. So this brings us to the end of hernia and abdominal wall overall, and this will cover entire GIT.